Welcome, everyone. I'm Diane Zapersky-Qualley, the co-founder of Beacon, and I am so thrilled to have so many of you joining us this evening for our Ask 2021 Ask the Experts event. We've had more than 500 people registered, so I know this is going to be a very wonderful program. We're looking forward to an engaging conversation with two experts who will be discussing promising advances in bladder cancer research and answering questions submitted by so many of you. And please stay with us till the very end, as we'll be announcing the winner of our first Beacon of Hope Award. When my late husband, John Qualley, was initially diagnosed with bladder cancer 21 years ago, there was little activity in the bladder cancer space. Our research community was small, funding was almost non-existent, and there was no patient voice demanding new and better treatments. As many of you already know, Beacon was created to address this void. When I contrast that year 2000 picture with today, I am amazed and excited. Now there are major institutions around the country that have centers dedicated to bladder cancer. There is increased funding from the National Cancer Institute, as well as the Department of Defense. Many pharmaceutical and biotech companies are devoting resources to finding new treatments. Clinical trials are ongoing across the country, enrolling the necessary patients quickly and answering important questions. And we have many new treatments approved. Since Beacon began 16 years ago, thanks to the generosity of our supporters and our community, we've invested $6.7 million in bladder cancer research. The foundation of our research program is our belief that today's research fuels tomorrow's cures. Our research grant program focuses on investing in people, encouraging the best and the brightest clinicians and scientists to dedicate their expertise and talent to a career focused on bladder cancer. Since 2013, Beacon has made 20 Young Investigator Awards, and tonight we'll be announcing the 5 recipients of our 2021 awards, yet another reason to stay with us till the very end. These awards are very effective in enabling these early career investigators to become leaders in the bladder cancer field in a variety of areas, including improving our understanding of the genetic mutations that contribute to disease progression, leading clinical trials of promising new treatments, and identifying ways to improve the quality of life for bladder cancer patients. We are so fortunate to have 2 of those outstanding former young investigators with us this evening. It's an honor for me, there we go. It's an honor for me to first introduce Dr. Kent Mao, who received the Young Investigator Award in 2016. Dr. Mao is now co-director of the Bladder Cancer Center at Dana Farber Cancer Institute and Assistant Professor of Radiation Oncology at Harvard Medical School. Welcome, Kent.
Thanks, Diane. It's great to be here.
I'm also honored to welcome Dr. Sarah Psutka, recipient of a Young Investigator Award in 2019. Dr. Psutka is a urologic oncologist at the Seattle Cancer Care Alliance and assistant professor of urology at the University of Washington. So happy you could join us, Sarah.
Thank you so much for having me, Diane.
Both Kent and Sarah are actively engaged in the Beacon community in so many ways, including serving on the steering committee for our annual bladder cancer think tank meeting, as well as leading sessions for that meeting. We will not be taking questions through the chat this evening. We've received over 200 questions from participants this evening in advance, and we're going to do our best to capture all the major issues and concerns raised, but I will apologize in advance if we don't get to your particular question. We will be posting links in the chat to Beacon resources for additional information, so I hope you will find that all helpful. So without further ado, we're going to get started. And I'm going to start because a lot of our focus this evening is going to be on the impact of research and research advances. So Sarah, I'm going to start with you. What new treatments or protocols are you using today to treat your bladder cancer patients that were not available 5 years ago?
Well, it's amazing, as you said, Diane, the environment that we practice in is vastly different today than it was even when I was in training about 6 years ago, and then even before that. The advances over the past decade, I think, we've really revolutionized how I think about bladder cancer. We've started to characterize the genetics of it in a much more granular and detailed way than we ever had the ability to do before. In terms of new techniques, I would say that one thing that has really changed how we handle the diagnosis of bladder cancer has been the uptake of enhanced cystoscopy. So many of you will be familiar with the concept of blue light cystoscopy or narrowband imaging, which are two advanced techniques that allow us to basically perform a cystoscopy during which we identify the bladder cancer tumors and to identify them with greater sensitivity, which means we do a better job of finding smaller tumors that hopefully are earlier in their pathway. We catch them earlier, we identify them, we stage and describe the tumor more efficiently and more effectively. And that allows us to develop a more appropriate care plan so that we're not undertreating tumors, we're identifying tumors. It's not a question of seeing an early recurrence at 3 months because the cancers because we actually missed a small tumor 3 months ago. And hopefully in doing so, we're sort of changing outcomes for patients. And I think that's really been a big advance.
That's great. And Kent, how about for you? The same or something different?
Yeah, so echoes Sarah's sentiment that the landscape looks different, just over the course of my career to date. And, to sort of build on what Sarah said, a couple of things that come to mind in the treatment space, especially for muscle invasive and advanced disease, are the approval of really now multiple new systemic agents, immunotherapies being one of them. And I'm sure we'll talk about immunotherapy as well as many of the other newer therapies. But their uptake and use in the advanced disease setting, I think, has revolutionized sort of the progression in the landscape of bladder cancer. And then for the muscle invasive space, I'm a radiation oncologist, and just thinking about how I treat patients with radiation now compared to even 5 years ago, we're using new imaging modalities to try to increase radiation dose to the tumor and reduce dose to normal surrounding tissues to hopefully minimize side effects but maximize cures. And we're combining radiation with many of these new systemic agents, chemotherapy, immunotherapy. Most often in the context of clinical trials, I would say roughly half the patients I treat are enrolled in a clinical trial that's combining radiation with one of these newer agents. And I think that's exciting and has the potential to really help patients get through their treatment and then keep their disease at bay going forward.
Yeah. So following up on that, then, can you give us one thing that you're most excited about that's in the research pipeline now that you hope to be using for your patients in the next 2 to 5 years?
Yeah, that's a tough question because there's many, I think, but to sort of build on what I began with, I think that it's feasible that in 2 to 5 years for patients with muscle invasive disease, we will be using genomic biomarkers to really help guide the systemic therapies that we combine with things like surgery or with radiation. So depending on a patient's specific tumor genetic makeup, we can select the drugs that we think they're going to be most likely to respond to and combine those with either surgery or radiation in an effort to maximize the cure rates.
Great. And Sarah, how about you, putting you on the spot, one thing you're most excited about?
Well, I think just to piggyback on what Ken said, the thing I'm most excited about is personalizing bladder cancer care. This is 2021 is a very different time to be treating bladder cancer because of the fact that we have a lot more options. But what we're trying to figure out is when do we use them? And I think that we're getting, as we understand more about the genetics of bladder cancer, but we also understand more about these different types of bladder cancer, we're starting to really get down into characterizing cancers into their different sort of histologies, which means what kind of cells make up the cancer. Mm-hmm. And then also, Diane, you know this, I'm really excited about understanding more about the patient themselves and understanding more about a patient's own innate vulnerabilities, so risk factors, frailty, comorbidities, physiologic age, body composition, those sorts of things, and how the patient sort of personalized risk factors, and then also their strengths, so their own innate resilience, their own innate physical fitness, their nutritional parameters, how those interact with the disease. And that can help us sort of identify, when it's appropriate to kind of potentially use, for example, immunotherapy in the neoadjuvant space versus using chemotherapy in the neoadjuvant space versus using cystectomy as an upfront treatment modality. So how do we sequence all of these tumors? When do we go with radiation? When do we go with surgery? When can we give, we don't know this yet. We're still trying to figure it out. When can we give systemic therapy and not follow it up with something like consolidative surgery? Right. A lot of questions we have to answer, but I think we're getting closer to being able to put a much more personalized spin on how we handle each of these diagnoses. And that's something that I think is really exciting.
It's incredibly exciting, and recognizing that every bladder cancer patient is different. Mm-hmm. And it's as we like to say, an N of one. And so what works for John won't necessarily work for Jim, and really finding what's going to work for them. And that is really exciting. So just one of the questions we got is, and I think you touched on it a little bit, but Kent, can you speak a little bit more about the value of tumor genotyping, about getting a genomics report, and which patients should be getting that, and when in the whole treatment line should that happen?
Yeah, I think that's a great question, and one that I think the answer is complex. So I would say that the majority of our patients that we're seeing at Dana Farber who are presenting with muscle invasive or advanced bladder cancer will have tumor genomic profiling performed at some point during their treatment course. As is often the case with new therapies, often they are tested in the later stages of disease, and once they've proven to be active in that space, they tend to move forward. And so, patients with metastatic bladder cancer now have, half a dozen or more different treatment options than they had 5 years ago. And those same treatments now are being moved into, say, the muscle invasive space or even the non-muscle invasive space. And so, for many patients with advanced disease, there is sort of a standard algorithm where we continue to try to use, one of a handful of regimens. Mm-hmm. I think we'll continue to build out that in personalized therapy, but especially, for those patients whose tumors don't respond fully, or who need additional therapy. I think there is when the tumor genomic profiling can really inform therapy selection. And so we had our first targeted agent approved in bladder cancer, erdafitinib, a couple of, over a year ago now, which, patients undergo a genomic test, and for patients with a specific tumor mutation, they may be eligible for, for this specific therapy. And I think this is going to be one of the, I hope many examples to come where a tumor genomic profiling performed at some point during the treatment course has the potential to inform and guide therapy selection.
And Sarah, do you see that being important also in the non-muscle invasive space?
I think we're probably moving towards that. We currently have at least one trial open, and we're working on opening another one that is using a similar drug to erdafitinib, mm-hmm. That similarly relies on a patient's tumor expressing that specific mutation. So I think that we are moving that kind of genomically guided, personalized mm-hmm. Approach to the systemic therapies for non-muscle invasive disease earlier in the pathway. But a lot of that is under clinical trial investigation right now. So certainly I think that's coming.
Yeah, and I know that the cost of that genomic typing has been going down over the last several years too. It's still expensive, but not as cost prohibitive as it might have been 5 or 6 years ago. Mm-hmm. When we are talking about diagnosis, another question that came up is, we know that bladder cancer is most commonly diagnosed through a urine test and cystoscopy, at least in the non-muscle invasive space. Is there a blood test for bladder cancer?
I wish.
Where are we on replacing cystoscopy with either better urine tests or a blood test?
I can speak to that a little bit. So I think
Yeah.
we're a ways away from that, from it being ready for prime time. There are numerous active studies that are ongoing that are looking for being able to identify, for example, circulating tumor cells and other that we might be able to identify from a simple sample of someone's blood to identify if there's either a risk factor for harboring bladder cancer or a patient actually has the cancer. But unfortunately, we're not there quite yet. And then in terms of urine tests, there are a couple of different types of tests. I think I saw some of the questions that raised the concept of this test called CX Bladder, which especially it's interesting in the setting of COVID-19, where we couldn't get patients into the hospital as quickly, or in some cases, elective surgery was shut down and we were limited on who we could bring into the hospital. There was a push to try to rely on urine tests like that to identify patients that maybe we could hold off on bringing them in for a diagnostic or a surveillance cystoscopy. But again, it's not something that we can use as a blanket approach at this point. So I think it's best of, at least in my practice, they're not, and based on the guidelines, they're not considered standard of care able to replace cystoscopy. But we sure are working on developing those tests, because obviously cystoscopy is associated with a tremendous amount of discomfort, bother, financial toxicity, the number of appointments that patients have to come in for, in terms of loss of work hours, loss of time with their family, travel time. We're very sensitive to the fact that we do need to improve our ability to diagnose and surveil, especially muscle-invasive bladder cancer, better. But again, it's ongoing.
Okay. And Kent, how accurate are imaging studies like the MRI, a CT scan, or a CT urogram? And also, are PET scans ever used to detect bladder cancer?
Yeah, that's interesting. So certainly these imaging tests are the type of studies that get ordered for many bladder cancer patients, and CT, for example, is part of the standard workup, for patients with newly diagnosed bladder cancer. We use sort of a variety of imaging modalities in our practice because we feel like each imaging modality has a sort of specific advantages and disadvantages. And so CT is great to look for things like tumor in the bladder, tumor in the lymph nodes, swelling of the kidneys, hydronephrosis. MRI are something that we're getting for a lot more of our patients now. MRIs provide, I would say, the most sensitive look at the anatomy in the pelvis, and so we can use them to try to understand if a tumor is invaded through the entire muscular wall of the bladder into the surrounding tissues, or invaded lymph nodes. And so, as part of my practice now, for patients undergoing radiation, we use both information from CT and from MRI to help design our treatment fields. PET scan is interesting. I mean, unlike some tumors, for instance, lung cancer, where PET scan can be really informative, we are getting PET scans for some of our bladder cancer patients, but one obvious limitation of PET scans for bladder cancer patients is the tracer that's injected that lights up on the PET scan is actually excreted in the urine, and so the entire bladder lights up as a normal feature of the patient's excreting urine, and so you see this really bright blob, which is the bladder, and that can make it hard to differentiate urine containing the marker from bladder wall or bladder tumor uptake adjacent to it. So it can be good for finding things like lymph nodes that may be involved, but for assessing the bladder tumor specifically, CT, MRI, and then cystoscopy, as Sarah mentioned.
Okay. Yeah. And then we get this question very, very often. If my mom or dad has bladder cancer, am I at higher risk to get the disease? Basically, is there a genetic component? Either of you?
Yeah, that's a great question. And it's an area of such, I would say, intense research interest. I mean, as you know, one of our main sessions at this year's Think Tank is going to be on germline or hereditary risk factors for bladder cancer. And so I think that traditionally, historically, the answer would have been no, bladder cancer is associated with certain environmental or occupational risks, but isn't necessarily hereditary in the same way we can think about things like breast or ovarian cancer. I think that's actually an oversimplified view. And although I would say perhaps currently a lower percentage of bladder tumors are obviously associated with a hereditary pattern than are some other tumor types like breast or ovarian cancer, I think there is certainly a subset of bladder tumors as we learn more about the genetic makeup of these tumors, where it's quite clear that there was an inherited mutation or an inherited factor that increased the risk of development of bladder tumor and could have implications for the way that the tumor gets treated ultimately.
Okay, but so this is something we will know more about in the coming years. It's still uncertain.
Yeah, I would say to patients, this is something I would certainly, when asked about family histories of cancer, this is certainly something you bring up with your primary care doctor. It's not something that's currently impacting the way that we surveil or screen patients, but important to know that as we learn more, it's probably going to be the case that we begin to understand that at least a small fraction of bladder cancers are clearly due to inherited risk factors.
Okay. Yeah, I'm sorry, Sarah, go ahead.
I was going to say, I think it is interesting because I actually see a lot of referrals for patients who have been identified with other predispositions to develop, so genetic or familial predispositions to developing certain cancers. So for example, there is one syndrome called Lynch syndrome that we do know does increase the risk of for upper tract urothelial carcinoma and bladder cancer. And so those patients actually are followed a little bit differently. It's a very small patient population, but that's why when we take a family history, we actually really want to know if a patient, for example, if your parents have had these cancers, or if first and second degree relatives have, because it can sometimes trigger, if there have been, for example, a lot of colon cancers or GYN malignancies, it can set off some warning bells that maybe we actually do need to dive into it. And we've gotten in a lot of our and especially when patients present with young people with bladder cancer, we know that the median age of patients presenting with bladder cancer is 73 years. So when someone in their 30s or 40s present, that should be a trigger that we do actually probably need to dig a little bit deeper. And so I think it's one of those things, if your parents have been diagnosed, it's certainly something to bring up to your physician, because there are specific situations where we'll involve the genetic counselors and do some testing. But like Ken said, we're still sort of trying to figure out exactly what those different pathways look like and what those risks are.
Okay, good. So we're going to move on a little. We know that bladder cancer is not really a single disease. There's this very wide spectrum as it covers non-invasive papillary bladder tumors that don't invade the bladder wall to advanced metastatic disease that involves the cancer spreading from the bladder to other organs. So we've got a lot to cover. We might go back and forth through these different stages, but I'm going to start with non-muscle invasive. And as we know, the standard of care has been, in many cases, BCG. And we all know, too, that there have been issues over the past too many years with the supply of BCG. So we've had a lot of questions about BCG treatments as well as the alternatives. So I'm going to start first, Sarah, with just talking about BCG treatments. One of the questions we got is, how long can you stay on BCG maintenance treatments? Is there a maximum number of doses?
It's a good question. So the original clinical trial protocol that led to us bringing maintenance BCG into mainstream bladder cancer care suggested that patients should be treated over 3 years. So the protocol is you get a 3 doses, so I call them booster doses, at 3 months, 6 months, and then every 6 months for a total of 3 years. But we also know that patients can develop what's called Bcg relapse, so basically develop a non-muscle invasive bladder cancer after they've been on maintenance for some period of time. And if that's the case, we may actually go back and give people another induction dose, and if that's successful, go back on maintenance. So there's not an absolute maximum. In general, it's unlikely that patients are, and I certainly have patients in my practice, for example, who were diagnosed in, say, 2014 and went through the 3 years of maintenance. and then came into my practice in 2020, 6 years later. And then we resumed the process when they were diagnosed with a high-risk non-muscle invasive bladder cancer, where they got another round of induction and another, we're in the middle of maintenance. So there's not an absolute maximum. If a patient has failed induction BCG,
No. If the treatment has failed the patient.
I apologize. Exactly. And this is something that I just made a major slip. I'm going to turn red because I never say that. If the induction BCG has failed in a patient twice, if a patient has gotten induction BCG once and then gotten again, and the cancer has come back, we know that it's not worth doing it again. So we're not going to ask that patient to go through induction BCG or maintenance at that point. At that point, we're going to shift tactics and think about whether we we talk to patients about induction in intravesical chemotherapy, or I'm sure we're going to talk a little bit about the systemic immunotherapy in those patients. New FDA approval. I'm sure many of you have heard about this with Keytruda or Pembrolizumab. Obviously there are a couple of novel agents, one of which has been FDA approved, another which we're waiting on the FDA approval of, that I'm sure I noticed some questions on as well that we'll chat a little bit.
So yeah, I mean, that's the perfect segue, because the question was, when BCG is not available, what are my alternatives? And we know that is gemcitabine and docetaxel as effective as BCG? And then, well, I guess that's one question. Do you think that that's an effective alternative to BCG?
We do. Now, there's not level 1 evidence at this point, which means there's not a clinical trial where researchers have pit gemcitabine and docetaxel, which are 2 chemotherapeutic agents that are given in sequence. So a patient comes in, has a urine drain from their bladder, gets one of the chemotherapy agents for an hour, then that's drained out, and then gets the other chemotherapeutic agent. And then we do that 6 times in a row. And then maintenance for that is usually given once a month for 2 years. We haven't studied that against BCG in a clinical trial as of yet. There is retrospective data that is very supportive of the fact that at 2 years, there's about a 40% durable response. And so a lot of, in the guidelines right now, gemcitabine and docetaxel is considered appropriate for BCG unresponsive disease.
Okay. And you had mentioned Keytruda for an immunotherapy for non-muscle invasive disease. Who's eligible for that?
So that's for patients, again, with BCG unresponsive disease. And we use that term to define people who have gotten BCG, they've gotten induction. So it's usually the clinical trial definition is they got 5 out of the 6 rounds of the induction and 2 out of 3 of a maintenance. They've gotten at least, there's initial 6. It gets kind of complicated.
Yeah.
But they got BCG and it didn't work. Came back. And they got BCG again and it didn't come and came back. So if they have non-muscle invasive disease that's high risk, CIS is included, or papillary disease that hasn't responded to BCG, Pembrolizumab or Keytruda is FDA approved as a systemic therapy that's given through the IV, through an IV, usually once every 3 weeks in those patients. And there's a clinical trial that's a phase 3 randomized clinical trial that supported the use of Pembrolizumab in that space. And so generally the conversation we have with patients when BCG hasn't worked twice in a row or the cancer keeps coming back, we start to talk to patients about whether or not we think it's reasonable for that patient to go on to something like additional intravesical chemotherapy like gemcitabine and docetaxel, or move to a systemic therapy option like Pembrolizumab.
Okay. Kent, is trimodal therapy, chemoradiation, is it available for high-risk non-muscle invasive disease?
Yeah, that's a really topical question, because we're actually expecting results of a clinical trial of just that treatment paradigm to be reported later at a meeting later this year. And so the trial, which completed a couple of years ago, and we've been following patients since it was completed, were treated using a paradigm of chemotherapy and radiation similar to what we have typically used in the muscle invasive space, but applied to patients with high risk BCG refractory T1 disease. And so we expect results from that in a couple of months.
Okay.
Currently in my practice, I do use chemotherapy and radiation for, typically reserved for a very select group of patients for whom, they're not eligible for cystectomy, or, who choose not to avoid cystectomy. That's really what I'm reserving trimodal therapy for in the T1 space currently. And so it's not a, yet a sort of approved supported algorithm, but I hope that the results of this trial, which will be reported in a couple of months, will help shine some extra light on it, and may help that become sort of another arrow in the quiver for this, for this difficult clinical situation of refractory disease.
And Sarah, you had mentioned a new FDA approval and another drug that we're waiting on. Can you just touch on that briefly?
Sure. So there are two other intravesical therapies. One is called Adstiladrin, is the trade name, and nadofaragene firadonovec is the, which say that 3 times fast, is the generic name. That has been FDA approved, and that's it's basically a virus that's put into that carries something that is toxic to the cancer that's put into the bladder intravesically at 3-month intervals. And that's FDA approved, although it's not clinically, we aren't currently using that in practice a lot of places. It's still being sort of brought onto hospital formularies. So it's not quite mainstream, but it's got the FDA approval. The other drug is something called Vicinium, or opportunism. There you go.
Yeah. Vicinium is easier.
Oportuzumab monatox is another intravesical agent that I believe in August we will hear from the FDA about that's going to be approved. That's when I actually looked that up just to see if they'd given us a date, and they're late August. And so that's another intravesical agent that's given a little bit more frequently. The medicine is given initially twice a week in the bladder, and then weekly for about a total of 12 weeks, and then at maintenance doses. And the initial study demonstrates that that it seems to be very successful. The 2-year survival is very high at 95%, and it seems like the 3-month complete control rate is about 40%. So 40% of patients at 3 months don't have any bladder cancer in their bladder. So we'll see what the FDA says about that.
And just to clarify too, for any of our listeners who don't know, intravesical means it goes directly into the bladder as opposed to systemic into your whole body, correct?
Exactly. So we think of it as topical therapy.
Right.
It's medicine that we put in contact with the cancer, but it's not going through your blood.
Your blood. Okay, great. So let's move on to focus a little bit more on muscle invasive disease, when the tumor's grown deeper into the layers of the bladder and becomes much more problematic because it can progress and spread. And as we know, the standard of care for a long time has been bladder removal and reconstruction of a new urinary system. And so we have a lot of people who are very interested in knowing, and Kent, I'll start with you on this. What treatments are available to preserve the bladder? What are we looking at?
Yeah, so that's a great question. So the sort of the standard quote unquote, bladder sparing option today is chemotherapy plus radiation. And so it's called the trimodal approach because it really involves input and expertise from urology, medical oncology, and radiation oncology. And so patients will undergo a maximal safe transurethral resection of their tumor. So a cystoscopic removal of as much tumor as is safely possible. And then following that, the patients will undergo concurrent chemotherapy with radiation. And so the most common way that it's done in our center is it's about a 6 to 7 week course of daily radiation treatments given Monday through Friday, 1 treatment a day as an outpatient, with some chemotherapy during those weeks of radiation. And the way the chemotherapy is given depends a little bit on exactly what type of chemotherapy regimen is chosen to be given with the radiation, but it's typically once to twice a week infusion of a chemotherapy during those weeks of radiation to the bladder. The goal of this combined trimodality therapy is to completely rid the bladder of tumor. And once the patients are done with treatment, they go on to a surveillance protocol that includes relatively frequent cystoscopies, so examination for bladder tumors by a urologist, as well as imaging and blood work. And so that right now I would say is that's a standard approved approach for a bladder sparing treatment paradigm for muscle invasive disease. That said, there are, I would say, numerous other bladder sparing options that are under investigation. So for patients getting chemotherapy and radiation, there's a big trial going on now. It's a randomized trial that's comparing the standard of care, which I just sort of described, the chemotherapy and radiation, to that standard of care plus the addition of atezolizumab, which is an immunotherapy agent. The rationale being that atezolizumab is approved and has been shown to be active in patients with metastatic disease. And so we are trying to move it forward into the treatment paradigm and include it with chemo and radiation for patients with muscle invasive disease. And so that's a large trial that's ongoing currently. And then I'll just mention that there are, sort of combining our discussions about tumor molecular profiling with bladder preservation, there are several interesting sort of trials underway that are using tumor genomic profiling to select patients who are hopefully most likely to respond to chemotherapy. And so the paradigm for these trials is that patients, the standard of care would typically be chemotherapy followed by radical cystectomy. These patients undergo tumor genetic profiling at the beginning of chemotherapy, and then they receive the neoadjuvant chemotherapy as would be the typical standard of care. But rather than going directly to radical cystectomy, as would be standard, patients with specific mutations in genes involved in chemotherapy response in the tumor, they at the end of the chemotherapy, they have a cystoscopy performed. And if there's no evidence of tumor, they actually don't undergo cystectomy and instead follow a close surveillance protocol. And so it's a way to try to identify patients who are likely to respond to chemotherapy alone and give those patients the opportunity to keep their native bladder if the tumor completely responds to chemotherapy, once the chemotherapy has been completed.
Yeah, I think for me, one of the greatest advances that I've seen in the 21 years I've been in the bladder cancer space is this much more attention being placed on research to find ways for patients to maintain their biological bladders and not just assume that somebody with muscle invasive disease has to have their bladder removed. And so I'm really excited about all the different efforts that are underway to try to make that happen. I also want to give a pitch here for Beacon's clinical trials dashboard on our website. So if any of our listeners are interested in finding out about some of these trials that we're discussing tonight, you can go on there and find out where the trials are located and get some information to see if maybe you might be eligible now, or even if you want to consider it sometime later in your treatment. Sarah, is there any research being done into artificial bladders or some kind of transplant, so you don't have to, once you remove the bladder, because right now we use intestine to build a new system?
Mm-hmm. Yeah, it's a really good question. And it's actually been an active area of research for a long time. There's been much of the work has actually been done in the pediatric space, where, for example, some of the transplant surgeons have done work looking at whether or not we could use bladders from other animals, such as pig bladders, or whether they could grow a bladder in vitro, which means in a artificial system outside the body, that they could create a cell structure that looked and functioned like a bladder and then put that into a human. We're not quite there yet with a lot of those. And one of the sort of interesting things that people are doing now is looking at using 3D printing modalities to create cellular scaffolds, which basically means create something that they could then grow bladder cells on. And that could potentially be, hopefully, maybe someday transplanted into a patient so that we wouldn't have to borrow intestine to recapitulate some sort of internal plumbing that is not nearly as good as what we're all born with.
Right.
So yes, that's definitely an active area of research. Some really, really interesting work's being done there. The early trials with, for example, the pig bladder and the sort of artificial bladders showed that the bladders became pretty scarred pretty fast, and they didn't really work.
Okay.
But I think that that's something that it's been an active area of research for a couple of decades now. And certainly when I was in Boston, actually at Boston Children's, there was a really big lab that was working on that. So I think that, we'll see as the 3D printing modalities and also as the sort of cell culture, as our advances, we get better at basically growing normal bladder cells in culture. I think that there's certainly potential, but we're not there yet.
Okay, there were a lot more questions on this, but I want to move on to some of the other areas and move on to advanced or metastatic disease. And of course, we've had a lot of questions related to immunotherapy. So Kent, should you always try chemotherapy first, or is there, for some patients, should they just start on immunotherapy?
Yeah, it's a great question. So it certainly is a patient-dependent decision. So, a patient and their provider having this discussion. Currently, for patients who are eligible for cisplatin-based chemotherapy, and cisplatin is one of the drugs that's been shown to be most active in bladder cancer. The majority of patients who are eligible for cisplatin, and by eligible, I mean they have kidney function and they don't have kidney function that can support getting cisplatin. They don't have issues with things like neuropathy or hearing loss. For patients who are cisplatin eligible, most of those patients are recommended to have a cisplatin-based chemotherapy as their first line treatment for advanced bladder cancer. That being said, immunotherapy still plays a big role in many patients' treatment, because for patients who are cisplatin ineligible, now immunotherapy agents are approved in the first line setting. And so that would often be the first drug that would be given in a patient who wasn't eligible for cisplatin-based chemotherapy. And similarly, if a patient's tumor progresses through cisplatin, then often the second line of defense, the second line therapy in those patients is also immunotherapy. And so, I think a big percentage of our advanced bladder cancer population these days is getting an immunotherapy at some point during their treatment course. And that's where they're approved, and they're being tested, as we've sort of discussed, throughout the spectrum, including in the non-muscle invasive, where they're approved, and in the muscle invasive space, very active areas of investigation.
Yes. The FDA recently approved 2 new drugs for advanced bladder cancer, the antibody drug conjugates, which are Padcev and Trodelvy. I'm not Trodelvy. Trodelvy. How about that? You should say them, but tell me, how do they work and who are they for? And is there any difference between these 2 drugs? Either of you.
Yeah. So they're antibody drug conjugates.
Which means what?
Yeah, so it means that antibodies, which are proteins in your body that are designed to bind specifically to another type of protein in the body. And so in antibody drug conjugates, it's an antibody literally conjugated typically to a chemotherapy agent. And the rationale, the purpose of antibody drug conjugates is that the antibodies are designed to bind tightly and specifically to proteins that are highly expressed in bladder tumor cells. And so what you get then is delivery of this chemotherapy agent specifically to the bladder cancer cells at a much higher concentration than is sort of floating around anywhere else in your body.
Okay.
And so these are 2 different antibody drug conjugates that have been approved. The proteins that are targeted by the antibodies are slightly different in the drugs, and the chemotherapies that are attached to the antibodies are slightly different in each of the 2 agents. But the rationale, sort of their design features, are similar in that it's an attempt to more specifically deliver a bladder cancer cytotoxic agent to where the bladder cancer cells are, and relatively sparing more of the normal cells in the body.
Okay, but the approvals were patients can get this if chemotherapy doesn't work and immunotherapy doesn't work. It can't be the first thing that anybody goes to, correct?
Correct. The FDA approval for both of the agents, both enfortumab and then the sacituzumab, are the names of the 2 drugs that you mentioned. Both of them are approved in patients who have progressed through, or patients whose tumor has progressed through platinum-based chemotherapy, if they were eligible, and through immunotherapy.
Okay. We're going to go to a big area, but I've one question I want to ask about subtypes of bladder cancer, because I think it's really important. We know that the majority of bladder cancers are urothelial cell or transitional cell carcinoma, but we have other subtypes such as squamous cell and small cell and micropapillary. Are there research efforts underway or funds allocated to address the issues in these rarer forms of bladder cancer?
Yeah,
Sarah?
definitely. That's something I would say. You asked us at the beginning about big advances, and one of them is us being much more specific in how we talk about bladder cancer. We don't talk about bladder cancer now as sort of just bladder cancer in general. We know that bladder cancer gets broken down into these very specific sort of histologic types, which means what kind of cell is this cancer made of? Because a squamous bladder cancer is very different from an adenocarcinoma of the bladder, or urothelial, or micropapillary, or plasmacytoid, or any of these other types. They behave differently. So it's comparing apples to apples and oranges to oranges. They behave differently. Some of them respond to medications. So for example, certain of these tumors, like an adenocarcinoma, we wouldn't give neoadjuvant cisplatin-based chemotherapy. We wouldn't recommend it in that space. That a patient who has an adenocarcinoma of the bladder, we know that that patient should probably go straight to surgery if they're eligible to, if they have muscle-invasive disease and they're eligible to have their bladder removed. But there's a really a nice clinical trial that was published recently called the PURO-1 study that had a subpopulation where they were looking at using immunotherapy in patients who had variant histology, and demonstrated that there was some efficacy. And there have been some interesting studies recently that show that some of the squamous cancers actually express specific molecules that suggest that they are going to respond to immunotherapy maybe better than chemotherapy. So by being really specific about how we talk about cancers, and sure that when we get that first pathology report where we talk about what the cystoscopy biopsy showed, like what kind of cancer we're talking about, it can help us to start to really personalize whether we think that patients should go towards a certain cisplatin-based chemotherapy, immunotherapy, other types of chemotherapy. For example, in small cell, you mentioned that we use a different type of chemotherapy regimen there. So it allows us to be much more specific. And yes, there are quite a few active research studies that are going on. Ones where we're actually trying to grow these tumors in cell culture, but also in animals, so that they can test different drugs on them in a way that allows us to really study the efficacy of those drugs in a really targeted sense. And then the other big thing is actually just creating these, they're called tissue microarrays, which are basically laboratory tests that allow us to look at sort of how specific drugs interact with these different tumors. So that's a really hot area of research right now. And that's been an area that a lot of developments have been made in the last couple of years, particularly.
Great.
More information on that.
Great. So a big area of questions in this, of course, is bladder cancer has a really high recurrence rate. We all know that. And so there are a lot of questions that were raised about recurrence and the likelihood of recurrence. And we know that will depend on the stage and the grade often of the initial tumor. But one question that came up many times, is there anything I can do to help prevent recurrence? Does it depend on stage and grade? Can I do anything with nutrition, diet, exercise? Who wants to take the first shot at that one?
I know you started this.
I can speak to a few things. So there's, I would say, treatment-based strategies to prevent recurrence. So in the non-muscle invasive space, things like maintenance therapy in the bladder, whether it's maintenance BCG or maintenance chemotherapy in the bladder. In the post-cystectomy space, there are clinical trials going on right now where we are looking at whether or not giving people medicine after cystectomy, so that's called adjuvant therapy, whether that can help prevent cancer from coming back. So people, for example, who are really high risk of cancer coming back, who have stage T3 disease, tumor that's gone through the bladder wall, tumor in the nodes, they can enroll. There's a couple of clinical trials. There's one called the Ambassador trial. There's another one called the Proof 302 trial that's looking at using a specific drug that is targeted to patients who have a mutation in their tumor to prevent that cancer coming back. But what about, I think you asked a really interesting and a really smart question, is what can patients do themselves?
Exactly.
Medicines. And so the first thing is, if you have a habit in your life that we know, for example, is associated with bladder cancer. So the biggest thing is smoking. If you're smoking when you're diagnosed with bladder cancer, the best thing you can do is quit smoking. It's not easy. It's not easy at all, but you can work with your doctor, and there are strategies that we can offer that can help you to stop smoking, because we know that cigarette smoke and the chemicals in tobacco and in cigarettes are concentrated in the urine, and they predispose bladder cells to becoming cancerous. So that's something that's a major sort of step, a major moment of agency. It's a great time to start to make a big change in one's life. Nutrition-wise, there are things that we can do that basically improve your health. So patients who have cancer are recommended to make sure that they're eating a pretty healthy diet. One of the big things that we know about it, one of the big recommendations is protein intake. So there's an international guideline body that says that patients with cancer should be taking in 1 gram of protein per kilogram of body mass, which is a lot. So if you're a 70-kilogram man, that's 70 grams of protein a day, which is like bodybuilder levels. But the importance there is that we know that cancers increase your metabolism, and they accelerate the loss of muscle mass loss that normally happens with aging. Our chemotherapeutics and our treatments can also increase muscle mass loss, and muscle mass loss can make patients, it has a lot of implications, but it can make people more likely to fall and have issues around sort of independence of daily living, and have implications for quality of life. But there's also some pretty good evidence that it's associated with cancer coming back and with death from cancer. So by sort of fortifying your body with good nutrition and activity and maintaining your muscle mass, there's some pretty good evidence that that's likely to help. Now, those studies are also ongoing, and we're working on a lot of those as we speak. So good nutrition, exercise, stopping habits that are not so good, like alcohol and cigarettes. Those are all positive steps that people can take in their own lives to help reduce the likelihood of cancer.
So we have time for one more question, and I want to have time for both of you to answer this, because again, it depends on the patient and the stage and the type of disease they had. But how long do I need to follow up with my doctor, either my urologist or my oncologist, if I haven't had a recurrence? Let's say, Kent, I've had either I've had my bladder removed, or I've had successful trimodal therapy. I've been hadn't had a recurrence. It's been 2 years, 3 years. How often and how much longer do I need to come see you?
Yeah.
No offense.
Yeah. I'm taken. So it's very personalized. It really depends on exactly what therapy you got for exactly what disease type you had. But I would say that the good news, if there is some in this space, is that the further out you go from bladder cancer without a recurrence, we know that hopefully the less likely you are to have one. And so often much of our imaging and our cystoscopies and our surveillance is sort of front loaded in those first couple of years. And so for patients who have, who I've treated with this, who've had trimodal therapy, those folks, I see them pretty frequently the first couple of years, but then it begins to space out. And by 5 years, they're often done with much of the imaging. They continue often to have cystoscopic surveillance with their urologist. But again, sort of on a personalized basis, the further you go out, and 5 years is, certainly not an official, moment, but by that time, I'm often, not ordering as many or very few, if any, scans and things like that. And it becomes more just check-ins, cystoscopies for folks who still have a bladder.
Gotcha. And Sarah, looking at people with non-muscle invasive disease, and let's say I haven't, whatever therapy I had, and I haven't had a recurrence, when can I stop getting these frequent cystoscopies?
Good question. And it's a similar answer to what Kent described, which is that, again, especially we do everything, we try to be very specific and personalized. And so it's a risk stratified approach. If your original cancer was a low risk, non-invasive TA tumor, we used to see everybody sort of on the same regimen every 3 months for a period of time, then every 6 months for a period of time, then every year. But we know that those tumors are not likely to progress. And they have a high recurrence rate, but it's on a different timeline than, say, a high grade TA or a high grade T1 or a CIS. So we might see that patient at the person with the low grade TA at 3 months, and then if there's no cancer, and maybe 9 months later, and then every year or so. But the high risk patients, we definitely see them in a much more front loaded fashion, and especially if they're going through maintenance or something like that.
Okay.
I think that this question hinges on the key concept of survivorship. And that is something that is so important, right? The second I talk to patients about the fact that the second they're diagnosed with cancer and we go through therapy, you are now a survivor. But that does mean that in some ways, we sort of say, we're going to be kind of friends for a long time, because I end up seeing patients pretty frequently for much longer than that 5-year period. But even after the 5-year period, I think it's important to have kind of a handoff to the primary care doctor about key things that people should be looking for that should prompt a quick visit back to me. And I think that especially for people who have had cystectomies, we may decrease the intensity of our cancer checkups, so getting scans and things like that as much as 5 years out. But for example, if you've had a urinary diversion, I do want to check on you to make sure your kidney function is still good and your bone health is still good and your nutritional parameters are still good, because that's important to you having a high quality life with this new internal plumbing. So I think that it's a lot of follow-up. Being a bladder cancer survivor,
It's a lifetime.
a lifetime. It takes a lot of work, and you want to know who your people are. You want to know who your team is, and you want there to be good communication between your team, because even though you may not be seeing Kent or me anymore, you want to have our number in your back pocket just in case something pops up. So I think that you want to talk to your doctor about what those visits look like. I will say one other thing, an unexpected potential benefit of COVID, if we can say that there's any silver lining, has been we've gotten much more comfortable with telehealth and being able to see our patients in ways that are more efficient for our patients and less costly. Really expanded the ability of our ability to do that. And so I think we're working much harder here, for example, where our patients travel really far to see us, getting scans locally and doing checkups and discussing labs and scans over telecommunication. And if we need to examine them, that's different. But that also, we can do things to make it easier. And so I think, we don't have virtual cystoscopy yet.
Right.
But maybe
it's just, we could get rid of cystoscopy altogether. I think that would be great. That would be great. Well, we're coming up to the end of our hour. Stay with me for a few more minutes, Kent and Sarah. And it's been a wonderful conversation, and this could go on for hours, but unfortunately tonight we only had 1 hour. But right now it's my great pleasure and honor to announce the recipients of Beacon's Young Investigator Awards for 2021. For our Patient-Centered Clinical Research Award, Dr. Svetlana Avulova from the Mayo Clinic. There she is. For our other Young Investigator Awards, Dr. Philippe D. Carvalho from Brigham and Women's Hospital, Dr. Brendan Guercero from Memorial Sloan Kettering Cancer Center, Dr. Benjamin Miran from Fox Chase Cancer Center, and Dr. Eugene Pietzak from Memorial Sloan Kettering Cancer Center. Congratulations to each of you, and thank you so much for your commitment to improving the lives of bladder cancer patients and their families. And last but not least, I'm so pleased to announce the winner of the first ever Beacon of Hope Award. This award is presented to that special person who served as a beacon of light in someone's bladder cancer journey. Out of many nominations, members of the Beacon community have been casting votes over the last few weeks for 3 finalists. The finalists are John De La Garza, a caregiver to his wife Dorothy, a bladder cancer patient; Noel Lippman, a bladder cancer survivor and support to Dan Miller, who received his own stage 4 bladder cancer diagnosis; and Dr. Jonathan Wright, medical director of the University of Washington Medical Center Urology Clinic. With more than 800 votes cast, the winner is Noel Lippman. In his nomination for Noel, Dan Miller wrote, "Upon hearing about my diagnosis, Noel, a 9-year bladder cancer survivor herself, immediately dropped everything and came over to talk with us and comfort us. Noel is not the only inspirational contact that we have met since the diagnosis, but she continues to be the person who helps keep the light in this journey's tunnel well lit and keeps me moving forward one step at a time." Congratulations, Noel. We're so happy for you, and we'll be in touch with you shortly to make sure you get your award. So thank you to everyone who submitted nominations and participated in the voting. And many thanks once again to our experts, Dr. Kent Mao and Dr. Sarah Psutka, not only for sharing your time and expertise with us this evening, but for everything you do for your patients and for the Beacon community each and every day. And thanks to everyone who joined us. Please visit our website regularly for additional resources. And I hope we can all be seeing each other in person very soon. Good night.